Hey everybody, welcome back to another episode of Hybrid Healing Hour. Today we are going to be discussing preventive cardiology, and we not only have a friend and colleague of ours, but a very knowledgeable preventive cardiology nurse practitioner with us, Deirdre Detraz. Why don't you go ahead and tell our audience a little bit about yourself and how you got to where you are today?
Okay, perfect. Thank you all so much for having me. So as Deanna said, my name is Deirdre Detraz, and I'm a nurse practitioner, and I practice in Lafayette, Louisiana. I started out in a background of traditional cardiology. So I know very well what that looks like when you have workups and stuff. And I very much enjoyed my time for almost 7 years in a traditional setting. But it was really almost heartbreaking sometimes to know that that heart disease is still our number one disease threat. And I always thought that there has got to be a better way to get on the forefront of this disease. So I kind of took it upon myself to start going to prevention conferences, cardiometabolic conferences, and just learning more about prevention. And I was afforded the opportunity in my prior cardiology group to actually run a prevention center for them for the last 5 years that I was with them. And that really ignited my passion to see that there really was a way to detect this disease early and to really run on a prevention side of things. So back in 2012, that's hard to believe that's already been 13 years ago, that I actually stepped away from my traditional cardiology practice and opened up Apex Prevention, which is focused on early detection, prevention, and really reversal of our cardiovascular diseases, heart attack and stroke primarily. So I've been on a journey now for 13 years as a solo practitioner, trying to prevent heart attacks and strokes, really kind of one person at a time.
And we should mention that how the three of us met. The three of us are all members of the American Society of Preventive Cardiology, which we have a few practitioners who also listen to this podcast, and it's such a great organization. They put on such excellent lectures, and once a year they have a big meeting, which is usually all over the country. It moves around. But, you know, when we first met you, we were very impressed with your knowledge and your dedication to the field of preventive cardiology. And the American Society of Preventive Cardiology originally started out as a women's cardiovascular prevention society, which it's morphed now. But once upon a time, it was largely geared towards women. And it's, like I said, it's an amazing organization, and we learn so much every year, and we learn so much from talking to people like you.
I love Deirdre's drive and passion for this topic. And, that's why I'd love for you to kind of touch on what a typical visit with you is like compared to a typical visit with like a, traditional cardiologist.
Okay, that's a great question. So typically how our office is set up is new patients will contact the office, and we have, standard kind of questionnaires, demographics, insurance, that kind of basic thing. So usually the first visit to the office will consist of a very comprehensive lab draw. So we do the kind of standard of care testing in terms of looking at liver and kidney functions and cholesterol. But really what we do is take a way deeper dive into the cholesterol aspect of this. So looking at advanced lipid testing, looking at the quality of the cholesterols. Probably what we hang our hat on is our inflammatory biomarkers, which we can assess through blood work and urine test, which is nothing spectacular, but because traditional people are at an office are getting blood work and urine tests done anyway. We do a lot of genetic testing as well, and we do a comprehensive dive also too into hormones and thyroid function. Almost in a nutshell, I say anything that has to do with the health of your blood vessels, we're going to try to at least assess and optimize in the office. So you come in for your blood work and your urine tests, and at that time we also capture a carotid intima medial thickening ultrasound, which is a non-invasive ultrasound done of the carotid arteries that goes beyond a standard kind of carotid duplex that look for luminal disease. We are actually looking for the thickness of your carotid intima media, because we know that plaque now forms in the wall of the artery, and it has growth in an outward direction before we have luminal involvement. So we do the non-invasive ultrasound and your lab work, and all of that comprehensive testing probably takes about 3 weeks to come in. So about 3 weeks after your initial encounter at the office, that's where we sit down and really dive into, consider the meat and potatoes of really now interpreting what the inside of your body has actually told us. So a new patient visit will on average last about 2.5 hours as we go through the education of how plaque gets deposited, where plaque gets deposited, because it is not as we originally thought in the lumen. We have lots of visuals that we can interact with patients to make sure that they really understand the how and why of their disease process, because then that makes our recommendations into how to address these things. It hits home a lot more because people own the why. And then we really approach, after we interpret all of the blood work and the ultrasound, is really come up with a customized approach for each individual patient, because what looks optimal for me may look very different for each one of you guys. And as is true with all of our patients, every physical body is a little bit different as to what they are capable of handling and what they need more of and what they need less of. So that's how a traditional, well, that's how one of our appointments would start. And then we always approach when we do find number one, disease, or we find inflammatory biomarkers. Now the really medical investigation comes into play is why. Why does that person have plaque? Why does that person have, inflammatory markers? Because we know that inflammation is an absolutely root cause of all vascular disease. So all of the things that we know, and it's a multitude of things that now have actually been proven to cause vascular disease and atherosclerosis, that's how we approach our patients. Is we want to find every root cause. We don't want to approach people from a risk factor, because risk factors, we know, are very kind of loose associations. We want to know directly what is actually causing plaque to be formed, because if we don't ever figure out the why, we don't give our patients an opportunity to not only halt this disease process, but to actually give them a fighting chance at actually reversing it.
Do you mind if we touch on what some of those cardiac inflammatory markers are that you check?
Absolutely. So probably the one that is most familiar to providers practicing now is our high sensitivity C-reactive protein, an hsCRP. So it varies a little bit different in our standard kind of CRP, which is a very general marker of inflammation, which can be elevated in any disease process or any inflammatory response, whether it is cardiac in nature or not. So the high sensitivity C-reactive protein does tend to be a bit more specific to the endothelial wall, or the layer of skin that lines the inside of all of our arteries. So that is the first one that we check for. Some of the more intricate ones include an LP-PLA2 activity and a myeloperoxidase, also known as MPO. And we do those specialized testing through Boston Heart Diagnostics. And two of our other inflammatory markers, which are actually checked for through the urine, which are a microalbumin creatinine ratio and an F2 isoprostane, those urine tests are sent off to Cleveland Heart Lab for investigation. So for every patient, we start out with the total of those 5 inflammatory markers.
And it's like putting together a puzzle, right? Heart disease is not just one thing. So a lot of times we tell our patients, and I'm sure you do too, that we have the ability to catch heart disease very early. So when someone comes to us, they may be 20 years away from their heart attack or whatever's going to happen to them. And a lot of times when we catch heart disease early, patient will say, well, should I be seeing a cardiologist? And not necessarily, because a cardiologist is going to take care of problems once they've already occurred, whereas preventive cardiology is taking care of the problems long before they happen.
Yes, that is exactly right. And unfortunately, this is a disease process that is very asymptomatic, meaning you do not have any symptoms, you don't see it, you don't feel it, there's nothing obvious till really, really late in this disease process. So we know statistically that sometimes a third of the patients, their very, very first sign of heart disease is actually death. They don't even make it to the hospital. A third of the time, you're going to have some type of traditional risk factor, whether that is chest pain, shortness of breath, short of breath with exertion, some exertional fatigue. Even a third of the time, you'll have some atypical symptoms, but you're at least going to feel something. That could be back pain. It might feel like epigastric pain, or it might feel like reflux. Or it
like
might
heartburn.
be right-sided pain, or it might be, things that you not necessarily would clue a clinician in to think heart disease first. So you're right. And by the time these symptoms are occurring, this takes years, if not decades, to form. Which again, in cardiology, the tests that we have available to us right now do a really great job of picking up disease inside the lumen. But as we mentioned earlier, that's not going to happen for years, if not decades down the line. So it's really trying to adopt these modalities of testing, and luckily a lot of them are non-invasive, to look for what we call subclinical disease, looking for plaque deposition before it's evident in the lumen, where we would typically pick that up, through angiography. Now, I'm very excited about people starting to get on board with at least calcium scoring. I feel like there's a lot of data out there. So people there, as we all are, very evidence-based driven, is utilizing that low-dose CT scan to look for coronary calcium. And I do utilize that in my office. I tend to not use it as my first line look into vascular disease, just for a few limiting factors. First off, I typically don't use them in my young population. I'm going to say pretty much anybody below the age of 50, because calcium scoring by design was to pick up calcified plaque. Well, we know that when plaque first starts to form, it is very, very soft, and it is a very, very almost spongy texture. And then over time, again, years, if not decades, as that plaque wants to stabilize, then it actually starts having calcium deposit in that actual plaque. And again, as we now know, calcium or calcified plaque is really a stable plaque. That's not a plaque that is going to be vulnerable to plaque rupture. It's typically not going to be the plaque that is going to be the cause of the actual heart attack or the stroke or the true event. We know that the soft plaque or the homogeneous plaque is much more vulnerable to inflammation. So that's the kind of plaque that will get really, really restless almost if it's inflamed, and that's what becomes more likely to tear through the endothelium, leading to the thrombotic event of being the unfortunate heart attack or the stroke. So a calcium score will be helpful in maybe defining how much calcified plaque that you have. So sometimes you can have a false sense of security if you have a calcium score of 0, because that doesn't necessarily mean that that patient does not have plaque. It just means that you don't have calcium.
Correct.
So a calcium score is extremely helpful to me if it's anything but 0. And I know a lot of data says start to be concerned at 100, start to be concerned at 400, whatever the schools of thought want to adopt. But really, if we want to be really aggressive in prevention, then we have to understand that anything besides 0 is plaque. Whether that's 1, whether that's 5, whether that's 40, that is identifiable plaque, and that patient deserves to be taken a step further and really trying to investigate why. So it's kind of my take on calcium scoring. I think it is useful if it is anything but 0, but a calcium score of 0 doesn't necessarily let us off the hook.
I couldn't agree more.
Yeah, you said that
Yeah.
You said that really well.
Yeah.
And now that calcium scores have become so common, there's a lot of misconceptions about calcium scores. And patients think that calcium is the problem, where it's not. It's a marker of the problem. And they also don't understand that if you go on treatment for your cholesterol, your calcium score is probably going to go up. Doesn't mean you're getting worse.
That's exactly right. And that's kind of I guess a little challenge that I personally have with my fellow colleagues that are in cardiology, and why I don't ever push for serial calcium scoring. So if you have a calcium score and it's anything but zero, to me that's end of story. You should really never have another calcium score, because as you mentioned, Brian, calcium you can't make go away. Now we know that if you have soft plaque, that is capable of regression, but once something is already calcified, it's virtually cemented in the wall of the artery, and it's stable. It's actually not going to really cause you a problem. But you're right, if we're doing what we're supposed to for you in terms of trying to address now what could not be quantified on a calcium score, which is your soft plaque, is again, if we're doing what we're supposed to do, the soft plaque either will have the opportunity of regression or stabilization, which means calcium. So I have seen, unfortunately, a number of times where a patient has a calcium score, let's say of 50, and then 4 years later, 5 years later, they repeat the calcium score and it's now 400. And then everybody's up in arms saying, oh my gosh, you've just had all this progression of disease. Now we need to do all these testing. And I'm trying to pump the brakes and say, time out. Whoa, why do we want to do testing? This patient is, number one, asymptomatic, but understanding that they did not have progression of their disease. What they have had is stabilization of their disease, and we should be excited as providers that we were actually allowed them to stabilize what was originally their vulnerable plaque, which again could not be quantified in a calcium score setting. So I've seen, unfortunately, a lot of unnecessary testing by doing serum calcium scores and seeing that calcium score increase, because it's only going to go up. It's impossible for it to go down, which is why I typically use the carotid intimimedial thickening, because I like that better for, again, a few reasons. One, like the calcium score, it is non-invasive. Unlike the calcium score, there's no exposure to radiation. It's just ultrasound technology, so we could do it every day and never really be of harm to a patient. The carotids, we kind of focus on that area because it's one of the few places in your body that the large vessels, or the macrovascular system, is easily viewed by ultrasound, because it's fairly superficial. And the studies have actually, or the data tells us that there's actually a 75% correlation that whatever is happening to your carotids, the same thing is actually happening in the coronary system as well. So you can make inferences about lots of, in fact, there's from head to toe, we have about 30,000 miles of arteries, which is just amazing if you think about how beautiful the human body is. But 30,000 miles of arteries can be almost investigated just based on a few inches on your carotids. And then we can also look at the texture of the plaque via ultrasound. So we can see if that plaque is hard and calcified. We can see if it's soft. We can see if it's in an in-between stage, which is called heterogeneous. So hetero meaning two, meaning it's hard and soft. So that plaque looks more like a slush. So it again shows a plaque in transition trying to become more and more stable. And by watching the composition of the plaque and watching the actual CIMT, or the carotid intimimedial thickness, which is based on fractions of a millimeter, so it's an incredibly small measurement, is we can actually see progression, or actually regression, of this arterial thickening, if you will. I traditionally use a company called Vaso Labs, and I think that there is one other company as well that is kind of recognized on a national scale to actually do the CIMT measurements in the office.
Wow. Yes. And I'm glad. Now, I have a question. So if you have done a calcium score and their score comes back moderate, let's say 50 or so. Now, do you consider doing a CTA down the line possibly, or would you only do that if their LDL has not remained at goal of less than 70 or 55?
I would consider maybe doing a CTA, a CT angio, if a person is symptomatic, or if I have concern about some kind of congenital, or some kind of just I guess, an artery that I would not expect the anatomy to be of a natural route. Again, we're talking about a CT scan, so that's going to be something that we have to at least factor in radiation exposure to the particular patient. Is I don't know that just a calcium score would trigger any further testing to me, especially without any symptom associated with that.
What if their LDL is not at goal? What if they showed that they have atherosclerotic heart disease with a score, and then their LDL is not at goal? Say they refuse statin therapy, their LDL remains around like 112. So it's not crazy high. Yeah, I know. I'm putting you on the spot here. So it's, this is where I want people to see that medicine is an art, right? And right. It's utilizing our resources.
Okay. So this is also too, which we have very colorful debates with some of my colleagues as well, with LDL being a targeted target of therapy. I know I get a lot of kind of kickback in the fact that I am not overly concerned about what the actual LDL number is, but I get extremely concerned about what the LDL quality is, because not all cholesterols are created equal. And I know I have, again, cardiology colleagues that makes the hair on the back of their neck stand up when I'm like, I really don't care what your LDL is, but I do want to know what your apolipoprotein B is, because I want to know, does your cholesterol have more of a characteristic of a big, fluffy, buoyant cloud, which is going to be less problematic in terms of trying to develop plaque, or do you have small, dense LDL particles, which are going to be a lot more prone to creating plaque? So my target of therapy for watching cholesterol control is actually going to be focused on ApoB, or this apolipoprotein B, not the actual LDL number in and of itself. And usually if I have an opportunity to present, especially to colleagues that are actually prescribing medicine, is that maybe we should be thinking about LDL more of a measurement of compliance versus actually a target of like, we have to drive this number down. When I started in cardiology, this was probably getting close to 20 years ago. Everybody believed that if you dropped an LDL under 100, then we were at goal, everything was fine. And then we realized that obviously we haven't put a dent still in heart attack and stroke events. That's still our leading cause of death. So they said, okay, well, maybe 100 is not enough. Maybe we should drop this down. And some aggressive therapies now in different, schools of thought says maybe less than 70 becomes the target. Okay, so we did that for a good number of years and still not really slowing down this disease process. Now I'm even hearing about people trying to get numbers less than 55. And again, I know that there's incredibly bright people out there that do not believe that cholesterol can technically be too low. I respectfully disagree. I feel like you can get cholesterol levels that are too low, because again, cholesterol is necessary. It's kind of a building block for lots of things. It's imperative for our cognitive function, for our sex hormones and testosterone production. So it's really not the enemy, particularly as long as LDL particles are free floating through the blood. Cholesterol tends to become way more problematic when we have disruptions of that endothelial lining, where we have LDL particles that are actually getting inside the wall of the artery, and then they start wreaking havoc. But as far as for cholesterol free floating through the blood, it's not the enemy unless it gets into a place where it's not supposed to be, and then again we start having problems. So right. It is a bit of a catch-22 about, so patient not technically at goal with an LDL of 112, and now we have presence of plaque as determined by their calcium score. So the traditional setting would really drive to get that number under 70. But again, just because we drop it under 70 doesn't mean that's that we've achieved what we wanted to for that patient. We really have to look at it from a much broader view, because the LDL being 112 and that patient having plaque may actually have not a whole lot to do with their actual cholesterol levels. Now we need to look at the other root causes and see what else it is really at play. Do they have insulin resistance? Are we dealing with kind of a pre-diabetes number? What is their vitamin D level? Are we looking at vitamin deficiencies, which you mentioned that this patient may have either refused statin therapy or maybe attempted it and couldn't tolerate it. So, just because, and I feel like I've been on this planet long enough that I really do need to be, and we all really need to be respectful of patients, that we can lead them to water, but we really can't make them drink. So sometimes their view on statin therapy may not be shaped by personal experience. But again, as we know, if you get on the internet, you're going to see equally as much positive as you're going to see negative. So it's really talking through if you do want to make a statin recommendation, why do you want to make it? Is it for cholesterol? I know myself, I'm pretty exclusively use rosuvastatin as the statin of choice. Pretty much if somebody comes to me on anything else but that, it's typically their last day on it. We immediately move to rosuvastatin, just because with it being water soluble, its side effect profile is usually way better handled than most other fat soluble statins out there. It is a very potent statin, so we can actually use them at low doses and get nice reduction, not only in LDL. I jokingly say that watching LDL drop is kind of like Botox. It like makes you look pretty, but it doesn't make you live any longer. But where rosuvastatin really becomes helpful is really taking the quality of the cholesterols into play. That if a person unfortunately has maybe a lot of these small sticky BBs, we're really wanting to convert those more to big fluffy clouds. So I feel like that is one aspect where it's far more superior than any other statin that's out there. And the fact that to date, it's really the only standalone cholesterol therapy that really has been shown plaque regression to literally make plaque go away. And because of the Jupiter trial, we know its anti-inflammatory benefit. And even in a clinical setting, I personally, if somebody has had high inflammatory markers, so I call that hot blood vessel, I have personally never seen anything shut down a hot blood vessel more quickly than leaning on rosuvastatin.
And another inflammatory marker that I feel is on the rise over the last couple of years is uric acid. Is that something you've been checking in your practice?
We do. On our first patient profile, we check a uric acid on every single person that comes in the office. And I think maybe not uric acid in and of itself, but the fact that uric acid is very predictive of gout. Mm-hmm. And we know that gout, being an inflammatory disease, is actually considered to be a red flag, almost like a risk marker, to be screened for cardiovascular disease. So if a person has high uric acid, then I kind of put it on my radar to serial follow-up testing, just to kind of watch it come down as we make dietary changes, hydration changes. A lot of things can influence somebody's uric acid and gout potential. So I think it's probably because uric acid being a predictor or really almost even diagnostic sometimes too of gout is probably where that becomes its correlation with vascular disease is because of that inflammatory.
We talked earlier about there's a large genetic component as well. Do you want to talk about some of the genetic tests that you check?
Absolutely. So there's a few of them that we check for. The first one that we look at is called ApoE. Which people have the potential of having a 2, a 3, or a 4. And it's something that we get these alleles from your mom's side and your dad's side. So depending on what somebody's ApoE status is, we can actually tell if they're at increased risk for cardiovascular disease. That ApoE is also considered to be an Alzheimer's gene. So an E4 would be a carrier of the Alzheimer's component of this. But where that information becomes incredibly helpful is really trying to design somebody's dietary recommendations. Because we know if somebody has APO combinations of 2 and 3, that they're quite capable of perhaps handling a higher fat diet. Whereas an ApoE4 is really, really going to be focused on getting really restrictive of fat in general, but particularly animal-based fats. We like to adopt things that look like a Mediterranean style diet. even sometimes even call it Mediterranean twist on keto. Because again, we know if we can focus on good plant-based fats, nuts, seeds, avocados, olive oils, that's really going to be super helpful for most people. Again, some based on this ApoE, then we can even maybe incorporate things that are more fun, like cheese or, some other animal-based fats. And then also too, because of the a lot of information that they have through Dr. Dale Bredesen, who wrote The End of Alzheimer's, his data actually goes so far as to actually give us recommendations for fasting schedules for brain health, because his data focuses on early detection, prevention, and reversal of cognitive decline, dementia, and Alzheimer's. So again, having that ApoE knowledge of that patient, we can much better help design what their lifestyle kind of should look like, particularly in terms of dietary pattern. So that's one of the markers we look at. Another one we look at is the 9p21, which according to the Bell-Donine method by Dr. Brad Bell and Dr. Amy Donine, is what they have labeled as the heart attack gene, which about half of the Caucasian population is carrying at least one copy of that. But it helps. I feel like genetics are more important for me as a provider almost than the patient themselves, because I feel like it gives me the opportunity to know how aggressive I need to be with somebody, because of all the things that we know have direct causality to vascular disease. There's literally only 3 things, and I tell patients this every day, there's only 3 things I cannot fix for you. I cannot influence your age, I cannot influence your gender, and I cannot influence your family history and your genetics. That's it. So the way that I approach genetics is, if you happen to be somebody who has a genetic disposition towards heart attack or stroke, then that just means it's not okay for me or any other provider on your team to take a real lenient stance with you, to say, oh, okay, well, your cholesterol is a little bit on the high side, we're just going to watch it. That means next year we're going to look at it, or your blood sugar is running a little bit high, you should probably back off the cookies, we're going to recheck it in a year.
Right.
Blood pressure, all these things that oftentimes we're either like too busy, or maybe we don't have an appreciation for how important these things are for each individual patient. So that's what I explain to my clients, is to say, okay, if we have genetic disposition, then it's just not okay to leave you lenient. We want to mitigate this additional risk, because I feel like that's what life is about. It's about risk mitigation. So anything we can do to optimize this, we want to do that to make up for the few things that we can't. So that's 9p21. Another one that I adopted a little bit later into my career was something called the MTHFR, which again, I adore podcasts, because I feel like this is a grassroots effort to get information to the public. Because let's be honest, providers don't have most providers don't have an hour to sit down and really talk about these pointed topics. So it's very interesting to see this evolve over the last couple of decades, as the public is choosing to educate themselves, is they are becoming, to me, better patients coming in asking for these things. So MTHFR, again, is a very, very common genetic mutation that has to do with metabolism of B vitamins, particularly folate. So again, that can also increase somebody's cardiovascular risk. At times, it can actually increase clotting ability. So again, knowing how to, if somebody has these genetic mutations, it's pretty easy to overcome them by the use of methylation of the B vitamins. So methyl B12, methyl folate, which again, that's easy, like that's low hanging fruit. You can capture a lot of protection for patients with not having to always lean on pharmaceutical therapy.
Well, and the one thing, like I said, or like you said, I liked is that these are modifiable, right? So these are what I would consider as epigenetic. Just because you have the gene, you have the opportunity to not turn it on. Or if you turn it on, you can work hard to turn it off naturally with supplementation or dietary changes. And that's with the MTHFR. You know, there's a book called Dirty Genes out there by Dr. Ben Lynch, and I highly recommend people to read that if they have this gene, because he even gives examples of, yes, this is what I recommend you take, the methylated folate. But if you can avoid the synthetic form of folate, which is folic acid, which is fortified in all of these foods like cereals and breads out there that people in junk, it's in every like packaged good that they throw in to make it look like you're getting vitamins in your potato chips. Like, you know, but you can avoid those foods and you can actually refrain from turning on the gene. So I love that you check all those. We also did a podcast on ApoE as well. And if an audience wants to go back and listen, they can. So I think this has been amazing. Now, we talked briefly about the CIMT, and we talked about calcium scores versus CTA angiograms of the heart, but there's other imaging modalities that actually show signs of heart disease. And I think one of the big ones that I see is mammograms, and people don't realize this. Like, we can see calcifications in the breast tissue on mammograms, and it's not, yes, calcifications, if they're in a cluster, can be sign of like something alarming, possible cancer, but we're talking about vascular calcifications. So can you go ahead and tell our audience a little bit more about like some other imaging modalities that you've seen signs of atherosclerosis?
Absolutely. And that's a great point, because as we mentioned earlier, from head to toe, there's 30,000 miles of arteries. So this is a very global, this is a very systemic process that happens. If you have something going on in a negative way, like developing plaque somewhere, it is rarely, if ever, localized only to that particular area. So as you mentioned, that's a great example of having a mammogram. Lots of women do that. But if, and not always will the radiologist mention that, but if they're savvy enough to comment on that, I always welcome additional information. So as you mentioned, we're talking about in the arterial system. So a mammogram that would have said calcification in the mammary artery, that's vascular disease, kind of end of story. That patient should be treated differently. Sometimes even somebody has a chest x-ray, you know, or an abdominal ultrasound, and they'll make a comment about atherosclerotic changes or calcifications of the abdominal aorta. That's vascular disease. Even going so far, and we have a lot of dental colleagues, and this is why I think it's such an exciting opportunity to really collaborate with dentistry, is when you are doing your panoramics for your teeth, a lot of times they'll actually catch calcification in carotid arteries that you can see on an x-ray. It doesn't even have to be a really fancy cone beam imaging. Even our traditional x-rays, that's an opportunity for that dentist to mention, hey, have you ever had your heart checked out because you've got calcifications in the arterial system, you know? So really anywhere, if you have an x-ray of your leg because you broke it, unfortunately, if that radiologist, and I feel like it goes down, and I'm almost going to shout out to radiology, if you see, even if it's not pertinent to why the test was ordered in the first place, was to look at a fracture, if you see arterial calcification, that's extremely important for someone, maybe not the orthopedist that's looking for that. That could be very, very helpful to primary care, internal medicine, their preventative person, to actually know, because that's more information, because that gives us, not only does that patient have plaque, and that answers very, very definitely that yes, they do, but sometimes it's important for the patient to know how many systems are actually involved, or how many vascular beds, you know, is it only the carotids, or now they know they have it in, you know, their peripheral system, so they have it in their legs, and now they have it in the mammary arteries. Right. So I think the more you can build the case to show, hey, this is happening in more places than just this one, I think that would be a massive opportunity for compliance
and eye-opening
to realize the gravity of how many blood vessels are actually involved.
Well, and the size of blood vessels matter, right? I mean, we are talking about the heart from most of this, but you have microvascular system, which is in your eyes, your extremities, your toes, your fingertips. You've got macrovascular, like your aorta, which is massive. And like you've said, I mean, I've seen where incidentally reported on an abdominal CT scan showing atherosclerosis of aorta. And I'm like, if they have it there in a large artery, they probably have it in their heart or the carotids, right? And when it's in the carotids, that's closer to putting you at risk for stroke. That goes straight to the brain. And so I think people don't understand like the severity or the seriousness in having known heart disease or atherosclerosis. It matters where is it. And the eyes often can show signs of heart disease or blood pressure or diabetes, things like that, well before blood work and other signs are visible.
You are absolutely right. And I mean, for us to end up with 30,000 miles of arteries, that means the large majority of that mileage is actually in the microvascular system. And as long as I've been dealing with the human body, I am still in amazement and awe of it, because that means our microvascular system, we are talking about arteries that are about the size of a human hair. You know, I look at a human hair and I can't even believe, I'm like, you can even get blood to pass through that? Right. Much less have all these layers of an actual wall and for plaque to actually grow there. And that's a great point, because microvascular, because of its vulnerability of how small it is much more likely to be involved first in terms of plaque deposition before you're actually going to see it in the microvascular. Now, you made a comment about the aorta, and you said, and it's huge. It is huge compared to other blood vessels, but even that largest vessel, we are talking about the diameter of a number 2 pencil. That's not very big.
You're right.
You know? So by the time you're still talking about other large vessels like the coronary arteries that surround our heart and the carotids that actually feed our brain, you know, so that means those are even smaller than that. We're talking about traditionally, you can't really see it, but if you look at a pin, an opening of a traditional pin is about the size of a coronary artery. You know, we're talking about very small things that are getting stented and bypassed. Okay. So yes, the microvascular system, which again, if you have an occlusion in a something the size of a hair, that is not going to cause chest pain in that one little thing. You're going to talk about symptoms once they're actually involved in the macro or the big vessel system. But yes, for years, if not decades before that, especially women, which were much more prone to having micro vessel involvement. Also our diabetes and our pre-diabetes, which is running rampant in terms of insulin resistant, much more likely to have problems with the microvessel system. You mentioned the eyes. One thing that hits home, and I definitely want to take the opportunity to really, I do focus on women a lot, but men, erectile dysfunction. Mm-hmm. That is actually a precursor for cardiovascular disease. This is a blood vessel problem. And traditionally in otherwise young, healthy men, erectile dysfunction is actually usually going to present about 3 years before any traditional symptoms. So you're right. It's looking at how global, how many other body systems can actually clue us in before we're in a cath lab situation or fighting for our life. You know, to survive a heart attack or stroke. There is a way to do that, and it doesn't take a lot of invasive testing to really assess somebody from a vascular standpoint.
I agree, and this is why I love your passion, your drive. I love how you've been able to explain all of this to our patients and our listeners today. Is there anything else that you'd like to end off with?
Oh, man. It's a call for the public. It's a call to my colleagues. There is a way. I know we did not know that we could stop this disease process or much less reverse it. Now we know that beyond a shadow of a doubt. Johns Hopkins University looked at all of Brad and Amy, the Bale-Donine criteria, and actually proved reversal of vascular disease. we can actually stop this. We can actually reverse this, but we cannot do it unless we know why each individual patient is in this position to begin with. So risk factors, they're helpful. They're not going to put you on the forefront of this disease. Really looking at early detection so we can give people a fighting chance, customizing very, very precision medicine. It's an N of one. That patient is right there in front of you. They're going to need something very different than the next people that are going to be coming in your office. So I just challenge people to go beyond what the standard of care, what the guidelines are telling you to do. Just because something is not standard of care, not in the guidelines, by no means does that mean that's not evidence-based. By the time we're going to wait for the guidelines to catch up, the data is 20 years old already. So do more, not less,
And the one thing you just triggered a thought is how you actually review your blood work with your patients. And we do too. I always want our patients to come in to review the blood work for an appointment, and we don't just have a medical assistant or a staff call them and say, all your labs look good, doctor will see you in 3 months.
Or let the patients just look at the reference range and figure it out themselves.
Because reference ranges are not accurate on these things.
Well, they're not optimal ranges.
And optimal, exactly. So this is something that, there's, as a patient, we can give you the tools and the resources, but you also need to be your own advocate and you need to take charge of your own health. And if there's a suggestion, you need to put in the work.
Yeah, absolutely. And it's a team approach. Patients, if you're out there and you're feeling frustrated because you're not making any headway because you keep asking for this lab to be performed and, your provider is just not on board with doing that, please don't settle. There's lots of us prevention providers that are out there. Keep looking because we are there and we want to help and we want to do more. And I feel like with every passing day, people are getting more and more passionate, providers in particular, about wanting to learn more because people are sicker than they've ever been, but yet we have all this information, at our fingertips. So we're here to help. Please don't stop looking because we're throughout so many different communities. And just again, to my colleagues, anytime I have an opportunity to do any presentation to a provider, that hopefully we're evoking some little spark to make you hungry again, to do beyond what you're actually called to do. And I always like to end with a quote by Maya Angelou, who says that you do the best you can with what you know. And then when you know better, do better.
I love that.
Yeah.
Well, thank you so much, Dierdre, for coming on. Please tell our audience how they could find you if they're interested.
Okay. Absolutely. So again, my office is Apex Prevention. We are located in Lafayette, Louisiana, but we do take care of patients all over the country. So don't let the state line hinder you. We can be contacted at apexprevention@gmail.com. Our office phone number, if you'd like to reach us there, is 337-739-7278. And we are actually currently updating our website, which will be apexprevention.com.
Perfect. And I'll put all that in the show notes. Thank you so much.
Thank you for coming on.
Thank you, guys. Always great to be with y'all. Like-minded people.
Yes. Bye.
Appreciate it.
Bye. The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.